I'm gonna do this right now.
Are we doing both of those lectures today?
Um,
Consistently?
if we have time, we'll start the other one. If not, then we're gonna start with
Okay.
the mineral bone disease. Kathy's out of the office. Good grief.
Think there were still a couple more people on the other chat meeting.
On the other Zoom? Okay.
Oh, uh-huh.
Well, that one, for some whatever reason, is not updated yet to only 40 minutes. So if somebody could, I think Jessica sent out a message. Um, so if we could just make sure that they got the message. Appreciate any help you all can give me, because if I have to like sign off of this Zoom to switch on to the other Zoom. I won't start until everybody's here. Luckily we have time today.
We're we're back. I think there was only Farah and another person.
Thank you. I appreciate your help, Jose Yvonne. Ooh, we got a little bit to finish up from the anemia last week. Um, and then we will go into the mineral bone disorders. I always want to say density. I never, but mineral bone disorders. And then if we have time, we'll start the dosing. Tomorrow you will be in person with Dr. Gonzalez to talk about dialysis and dialysis dosing. And then Wednesday we are back on Zoom. I have a resident teaching on Wednesday. And then Thursday and Friday, we will be on Zoom. Friday is the cases. So if anybody would like to stay on and talk about what you've done for cases in cardio and what Dr. Gonzalez did earlier this block and what worked best for you, I would really appreciate feedback on what worked best so that I can tailor our approach on Friday um, to something that would be beneficial for you all. So if anybody wants to stay on and discuss and tell me what they liked and what they didn't like, we can work with that. The other thing is that there's no class on Monday. It's a study day, but I am willing to hold a exam review. So if you would like that, please let me know so that I can prepare that. It'll probably be either Kahoot questions or questions on slides that we go through and talk about the rationale for that. So please let me know if you would like me to put that together. Um, uh, there will be something on that day for an exam review, but if there's more, because those who scored less than a 70% on on the first exam are going to be required to go to that. But if everybody is going to attend, then I will like really beef up what we're gonna the exam review on Monday. Um, any questions on anything before we get started? I'm still going very sick, and going on day 10. So, um, of this. So I apologize again for the coughing and maybe some disjointedness in my delivery. But yeah, it's where we're at right now. So, so we had our first, Halloween activity. When I was a kid, Halloween only lasted one night. I don't know how it was when you were a kid, but nowadays we have like a bajillion trunk or treats and Halloween parties. My kid's social life is exhausting me. But this is the blue Power Ranger that we have in our house right now. His grandma and his aunt made the costume, and grandma always makes the costume for 2 years. So it's really big on him right now. And he was not very thrilled with me taking this picture because I was stopping him from going to the trunk or treat. So, um, yeah. So he's got a little disgruntled face. Okay, so let's finish up anemia. So we talked about ESAs and how they work. And so it's basically giving you the erythropoietin that your kidneys are not making anymore. Oh, sorry, I forgot to start recording.
Recording in progress.
Right. So we talked last Friday about ESAs and how they are essentially giving you the erythropoietin that your kidneys are not making anymore. And um, the erythropoietin, the ESAs are the construction workers. They're doing the building of the red blood cells, but we can't do the building without the building blocks, which are the iron. And so ESAs should almost always be given with iron, so that we have the construction workers and the building blocks working together to build those red blood cells. All right, we're going to start ESAs when the hemoglobin is less than 10. And we're going to try to keep the hemoglobin between 10 and 11, because as the hemoglobin goes above 11, we're at increased risk of thromboembolism, so DVT, PE, stroke, heart attack, and we don't want that. So like our magic number is between 10 and 11. We're going to use the lowest dose possible of the ESAs because they're not without risks, including high blood pressure being the most common. And then black box warnings for those thromboembolisms, and a black box warning for malignancy, because it's going to increase the risk of tumor progression, making your cancer worse. So we want to make sure people do not have cancer on these. So we now moving on to the building blocks, we have the iron therapy. And treatment candidates for iron therapy are patients with depleted bone marrow stores, so a ferritin less than 500, a TSAT less than 30%, um, and patients with a good response to the erythropoietin therapy, because patients with a good response to the erythropoietin therapy are going to be using those building blocks um, up, and we're going to run out of iron for those patients. So if they're having a good response, their hemoglobin is going up, then it's likely that their ferritin and iron is going down, because those construction workers are using all those building blocks to build those red blood cells, so that that the patient can be oxygenated. So the benefits of iron are that they treat iron deficiency, so that helps to raise our hemoglobin levels. They prevent the development of iron deficiency in patients that are on ESAs, and it helps to reduce the dose of ESAs, which is a safety factor for these agents. All right. Because remember, a patient can get anemia when they have chronic kidney disease because their kidneys are not working to make erythropoietin, but they can also get iron deficient anemia because they don't have a good enough diet to maintain the iron, and they're losing a lot of blood from blood draws to check their kidney function and their electrolytes. So the anemia and CKD is twofold. It's the anemia of chronic disease, and then there's the anemia of the iron deficiency. So most patients who have advanced CKD are going to end up on iron and ESA therapy. And if they're on an ESA, they need an iron supplement, because the ESAs are only effective when there is enough iron. So there's lots of different dosing formulations of irons. They come in iron salts. We have immediate release, um, salts that are generally the iron preparations of choice in regular patients that don't have CKD and are not on ESAs. Those are typically the drug of choice, especially for like maybe pregnant patients who are experiencing anemia. But when we're thinking about patients who have chronic kidney disease, we mostly need the iron, or the IV iron. I'm sorry, mostly need the IV iron to help with that. If we're taking oral iron therapy, We're dosing based on the elemental iron per day, and the side effects that you should be aware of are constipation, nausea, and abdominal cramping. This is the number one reason patients cannot tolerate oral iron. No formulations have been proven to have less GI effects. There will be some like slow FE that say, oh, more gentle on the stomach. And it's just a marketing scheme. Nothing has been proven to be better for patients as far as the side effects. So, number one side effect of oral iron therapy is constipation. It's hard stools, not necessarily anything to do with peristalsis. So if you remember what Dr. Hong and I taught you about constipation, um, the gold standard for treating uh, iron related constipation is docusate because the iron makes the stool hard. So we want to soften that stool. Now, I think that recommendation is probably a little bit out of date because docusate is kind of a crappy drug in not in the literal sense because it doesn't really work all that well, right? It's supposed to decrease the surface tension, bring in water. I think a better choice would probably be polyethylene glycol, but the textbook answer for iron-induced constipation is docusate. But nobody's doing studies right now on which is the best agent for iron-induced constipation. So we just go with our old tried and true. Okay, so to replete it,
I'm sorry, I have a question.
yeah,
For the oral iron, we're gonna give it per day? That one?
you're gonna you're gonna do what?
For the oral iron therapy, we're gonna give the iron like per day, like every day, not every other day.
Yeah, for oral iron, you would give it every day.
Okay.
Okay. So when we have to replete, when somebody's TSAT is low, when their iron stores are low, we want to give them 200 milligrams of iron, elemental iron per day. Ferrous sulfate has 65 milligrams per tablet. So they'd have to take 3 tablets a day to be repleted. And you can only take um, a little bit at a time because of the stomach issue. So that'd be like 1 tablet 3 times a day. And we know that increasing the number of times somebody has to take something decreases their ability to adhere to the regimen, right? If we have to take something 3 times a day, it's going to be harder for them to remember, hard to get those 3 doses in, probably not going to take the full 3 doses and therefore not get the full repletion that they need. So we also have IV therapies, and this is why IV is preferred because we bypass those GI side effects by using IV iron. All right. And so IV iron is especially preferred if the patient is on dialysis because they're already going to a facility to get the dialysis done. They might as well get the iron while they're there. We select the IV iron based on the cost, the number of doses, and the infusion speed, and what the patient has going on. There's a lot of different um, options for IV iron. We have iron dextran, which is a low molecular weight. It's in-fed. There's a black box warning of this for risk of anaphylactic reactions. And all IV iron has risks of anaphylactic reactions, but this one especially. And so it requires a test dose. So if somebody's going to get iron dextran, they have to have a test dose to make sure they're not going to have an anaphylactic reaction to this. This also means that all IV iron is given in some kind of healthcare setting, an infusion setting, or infusion center, hospital setting, dialysis center, because of that risk of anaphylaxis. We have iron sucrose, which is Venofir or Venofir. This one has a little bit better safety profile, but it still has that risk of anaphylaxis. And we have a lot of data with iron sucrose, and so this is one that we might want to use. The furomoxitol or Firaheem. This also has a black box warning for anaphylactic shocks, and this one also might interfere with MRI testing. So we have a patient that we think might need an MRI, we're going to want, or who needs an MRI and has gotten this, we want to be mindful of that because it can interfere with the imaging. So these are the three that I want you to know and be able to identify on the exam and what we need to do with them as far as whether they need a test dose, what are their interactions, what are their contraindications. Okay, so got a question in the chat going back to the oral iron every day. So there is a lot of controversy over whether that it can be given every day or not, based on absorption. And I have seen no good data to support every day or every other day. I think whatever the patient is willing to do is best. I think that the every other day dosing out there has not been shown to be much more beneficial than the everyday dosing, but I haven't dug into that clinical question in a couple years. So I can't really speak if there's any new data to that, but what the last data I saw is that every other day dosing may be more beneficial, but that the data wasn't strong enough. Also, that is talking about that is for people who are like mildly anemic. So, like when I was pregnant, I became anemic, and so I'm not, I'm still producing erythropoietin. I'm still getting iron in my diet. I'm just mildly anemic because your blood volume increases by 30% when you're pregnant. So, and every other day dosing for somebody who's mildly anemic might be appropriate, but for these patients who we are using these construction workers and burning through all their iron, we really need full repletion for them. So hopefully that helps answer the question.
But I didn't understand what's the logic behind the every other day. Is it reducing the chances of constipation, or like why would that be better for the patient?
Yeah, so it increases the tolerability, but also there is an enzyme, or there's like a rate limiting enzyme that helps with absorption that could be burned out by doing it every other day in theory. So there's another like scientific mechanism that I can't speak intelligently on without re-looking it up. So it's both efficacy and tolerability. And I have somebody saying that they always give IV iron in the hospital first, and now they know why. Because it's going to build those repletion a lot faster than the oral, because you don't have to absorb it. It's going right into the bloodstream. It, another question about whether we need a text dose or a test dose with ferriheme. From my review of the information getting ready for this lecture, I did not see anything about a test dose for ferriheme. Excuse me, or Venofir. Right. So when we're thinking about IV iron therapy, the number one reaction is allergic reactions or anaphylaxis. So please be aware of that. Even with the ones that don't require a test dose, you can get flushing, hypotension, and since this is being given on dialysis days, the risk of hypotension is real because when Dr. Gonzalez talks to you tomorrow about dialysis, the number one risk of dialysis during the session is hypotension, and he'll talk about a drug named midodrine. All right, so I'm just giving you a little precursor to tomorrow's lecture here. But if they're getting the iron while they're getting the dialysis, now we're adding another risk for hypotension between the pulling off the fluid and decreasing the pressure, the volume, the blood volume, decreasing the blood pressure, and the iron injection causing hypotension. Which can lead to dizziness, syncope, dyspnea, headache, arthralgias, pain, and we can get iron overload, right? We want to avoid if they have an active systemic infection. Uh, right. Sorry, my Zoom and slides did not set up the way I like them to, so that's why things are a little disjointed today, because I like to see your faces, but the way it's set up, it's not allowing me without. Anyways, so I'm looking, yeah. I am sorry. I am so sorry for the last week and this week. Even if I was feeling 100%, I don't know that I would have done any better managing all these Zoom issues. So I appreciate your patience with me, um, with this. All right, so looking at anemia of chronic kidney disease, iron therapy, and comparing oral to IV. Remember, IV is preferred because their stores are very depleted and it's going to be very difficult to increase their iron stores with the oral agents. We get more rapid repletion time. We get assured compliance because we know that they are getting it at their dialysis sessions. There's fewer GI side effects with it. But it requires IV access. So if they don't have dialysis, that can be a hard sell for them to go get the iron infusions, right? So we have to balance like what will the patient do with what is best for them. So if they're not on dialysis and they don't have IV access, it can be difficult to get them IV iron therapy. It requires monitoring. There's infusion risks like the anaphylaxis, and the cost is it's really expensive. Oral therapy, very low cost. Hard to say that it's high value because it takes a long time to replete with oral. So I would say low cost, mid value, because we're not necessarily getting the repletion that we need for these patients in particular. Okay. But it's readily available. You can buy it over the counter. There's no IV access required. Mild side effects, with constipation being the biggest one, but patients tend to not be compliant or adherent with it, and we can't really determine their compliance or their adherence. There's decreased absorption with it and absorption issues, and it takes a lot longer to get those stores up. So that's why IV iron is preferred. Right. So when you're thinking about studying for the anemia portion, you want to think about that it's the decrease. Anemia and chronic kidney disease is related to the decreased EPO production, along with some iron deficiency issues like decreased malnutrition issues because of decreased appetite, increased blood draws, things like that. So with the decreased EPO production, we get the decreased production of red blood cells, and our hemoglobin is going to be less than 13. Anemia equals hemoglobin less than 13. All right. If the hemoglobin is less than 10 and they have signs and symptoms, what signs and symptoms would indicate that a patient has anemia?
Tiredness, if person feels weak,
SOB.
Yep. Tired.
reduced tolerance of exercise.
Yep, reduce tolerance of exercise. And again, in these people, this is exercise would be activities of daily living. So getting up to go to the bathroom, making themselves a meal, things like that. Cold intolerance, pale, yes. All right, so hemoglobin of less than 10 is when we're going to start treating these patients. We're going to start with an ESA. We're going to replete that EPO. What are the risks with ESAs like darbepoetin or apotin?
Thromboembolism,
Sorry, George, what was that?
thromboembolism,
One more time, please.
thromboembolism.
Oh, thromboembolism. Thank you. So yes, a VTE. When is the risk of VTE the highest? When is the risk of thromboembolism highest?
The hemoglobin exceeds 11.
Yeah, when the hemoglobin exceeds 11. So we have to stop the ESA when the hemoglobin is over 11, because we increase the risk of thromboembolism if the patient is on an ESA. Right? The ESA is the construction worker or the building block.
Construction.
Yeah, it's the construction worker, and the iron is the building block. So which building blocks should we use in patients with CKD? Oral or IV? I saw Haiti mouth IV, I think. Everybody agree with Haiti? Oh yeah, and Jesse's giving me the IV sound. All right, so IV, because it's going to replete them faster, especially if we can give it to them during dialysis, assured compliance or adherence, whatever we're calling it right now. Oral is slower, more side effects as it relates to upset stomach, can't be assured that they're taking it, right? So make sure you're able to talk through this slide, and you'll be all set for this part of the exam, right? What questions do you have on this? We will move into the bone mineral disorders. Right, so going back to our Yellowstone vacation last year, and we walked around this peaceful little lake or pond, or we tried to anyways, until so we came in over here and are walking this way around the lake until we get to about over here and we see this bison just hanging out here. And we're like, nope, not gonna do this anymore. So we decided to, instead of going around and chancing it, that the bison would still be there, we turned back around and came this way. And then this nice peaceful lake became unpeaceful by rock throwing. And then this is like, since this is what National Pharmacist week or whatever, this is my all-time favorite. I think I have to reshare it because I don't think I shared the sound. This is my all-time favorite. You know, how your kid describes what you do moment. Thomas, what is mommy?
You're a pharmacist and you need to get some shots.
Thomas, what is mommy?
You're a pharmacist and you need to get some shots.
So, apparently the sound is very hard for kids under 5 or 6, and so he's telling me that I'm a pharmacist. So you're all in pharmacy school. Not to be confused with harmony, farm. All right. Moving on to the mineral and bone disorders. We've talked about the electrolyte and fluid abnormalities, the acid and base. Luckily, those are a lot easier, I think, in chronic kidney disease than they are in the acute manner that you talked about the first half of the module. We just finished anemia. So now we're moving on to mineral and bone disorders. So I want you to be able to describe the pathophysiology of mineral bone disorders, including the common abnormalities of calcium, vitamin D, phosphate, and PTH, and how they are interrelated. Design a treatment regimen for a patient with hyperphosphatemia and or secondary hyperparathyroidism, and design a monitoring plan. So the guidelines for the mineral bone disorders come from the KDIGO 2017. There is no update on that. So we're going to be talking about how mineral and bone disorders relate to CKD. We need to think about secondary hyperparathyroidism and renal osteodystrophy. So what do these things mean? So a systemic disorder of mineral and bone metabolism due to CKD, and these are manifested by one or a combination of these things. Again, we're kind of like, what came first, the chicken or the egg? But it's all from a result of renal dysfunction. So when the kidney doesn't work properly, we get decreased phosphate excretion, we get increased calcium excretion, decreased vitamin D activation, and so we start to see abnormalities in calcium and phosphate levels, as well as effect on the hormones like the parathyroid hormone and the vitamin D. Vitamin D is actually hormone. So clinically, we'll see these abnormalities in the bone because the bone is being turned over more frequently. And so the volume and growth and strength of the bone might be affected. So if we're turning over the calcium in the phosphate in the bone over and over again, what do you think that increases the risk for?
Osteoporosis.
Yeah, osteoporosis. Excellent. The calcium's moving out of the bone, it's not as strong and increases the risk of fractures. Okay. So we not before we see osteoporosis or fractures, we'll see above electrolyte abnormalities. We will see high levels of phosphate or calcium. And then if we have high levels of calcium and phosphate, when calcium and phosphate are together in the bloodstream, what do you think happens if you have high levels of phosphate and high levels of calcium in the bloodstream? Think about if you've made any TPNs at your place of work at IPPs, or if you work in a hospital and make TPNs, think about the way the calcium and the phosphate have to be added to the TPN. What do you think happens when calcium and phosphate get too close together in the blood?
Calcification?
Yeah, calcification. What do you think is calcifying?
Musculature.
Yeah, the vasculature. So calcium and phosphate together become calcium phosphate. That's calcified, and it starts to calcify the vasculature, which increases your risk for cardiovascular disease. That's why when we make a TPN, we put the calcium or the phosphate in last, because hopefully the calcium is in this big old mess and diluted enough that when the phosphate goes in, that it doesn't precipitate in the TPN bag, because if it precipitates in the TPN bag, that's really bad going into the bloodstream. Right. So thinking about the risk of this elevated calcium alone is linked to both morbidity and mortality, cardiovascular events. Both high and low phosphate are associated with mortality. And so we really need to work on managing this and helping to decrease that. But despite the association of higher mortality with elevated phosphate levels, the effect of phosphorus lowering agents has not been shown to consistently improve mortality. So We can decrease the phosphate levels, but that doesn't mean we're going to decrease the mortality. So if we're decreasing phosphate levels, is that a disease-oriented or a patient-oriented evidence that matters? Is it a surrogate outcome or a clinically meaningful outcome?
It's a surrogate.
Yeah.
Patient would not be able to tell.
Yep. So, it's a surrogate marker, but it's what we have to work with. And so we do still give medicine for patients who have elevated phosphorus because it can bind to the calcium and cause these other issues. So thinking about the bone mineral disorders, as the GFR decreases, the bone mineral diseases increase. So here we have a GFR of 80, and we have basically our calcium is low, or is not low, our phosphorus is not high. We have a little bit of PTH elevation, but not much. But as we go on and our GFR decreases, these significantly increase, and they significantly increase after 30. So less than 30, we see a significant decrease in calcium. We see a significant increase in phosphate and a significant increase in PTH. So we're not going to see these mineral bone disorders until less than 40, less than 30, of a GFR of less than 30 or less than 40. So this topic always kind of messes up my brain a little bit. So I have a bunch of different pictures to describe the process and the pathophysiology to you. And so this is the first picture that we have to describe the pathophysiology. And so in CKD, as it relates to phosphorus and calcium homeostasis, when we get to that stage 3, so less than 60, the phosphate starts not being excreted well because the kidneys are no longer able to filter it out, the phosphate, and it starts to be retained and accumulates in the body. So we start seeing an increase in phosphate here. And within the kidney, so we have the phosphate retention within the kidney. That is where our bodies are responsible for converting the precursor of vitamin D to the active form of calcitriol, or this 1,25 dihydro molecule here. And so our kidneys are not able to make this vitamin D active, so we get a decrease in the active form. All right. So right now we have low levels. I'm sorry. We have higher levels of phosphate because it's not being excreted, and we have low levels of active vitamin D because it's no longer being hydroxylated or metabolized within the kidney. So we start to get hypocalcemia. And because of that, we have feedback that leads to, we have the calcium sensing receptors on the parathyroid, and we start to get hyperparathyroidism because we have low calcium. And so the body's like, low calcium, we need to absorb more calcium. So we're going to the parathyroid to increase the parathyroid hormone to increase our calcium, right? When we aren't able to convert vitamin D to its active form, we get decreased absorption of calcium in the gut. We need this active vitamin D in the gut to absorb calcium. So we're going to have, that's also going to decrease our calcium because we're not going to be able to absorb it. So then again, that leads to more hypocalcemia, leading to more secondary hyperparathyroidism. And the reason it's secondary, so we have that hypocalcemia coming from here. And so it's secondary hyperparathyroidism because it's not a problem with the parathyroid. It is a problem of the kidney that is leading to a situation where the parathyroid is overreacting. So that's why it's secondary, because again, it's not an issue with the parathyroid, it's an issue with the kidney overreacting to the stimulus. Okay. So again, we have that vitamin D deficiency, reducing the intestinal calcium absorption, which is another stimulus for PTH secretion. So all roads lead back to hypocalcemia, which leads to increased PTH, which leads to secondary hyperparathyroidism. Kidney is going to fail to respond adequately to this PTH, and it's just going to keep going on forever and ever. So again, this is another visual of what's happening. We get the phosphate excretion reduced, so the phosphate goes up because it's not being excreted. We then get the kidneys cannot activate this calcitriol, this 125, they cannot hydroxylate that inactive vitamin D to calcitriol. So if we don't get calcitriol, we don't get intestinal absorption of the calcium, and we don't get um, calcium. We get calcium release from the bones, and we're not inhibiting this PTH because this calcitriol goes here and inhibits it. So we're not inhibiting that if the calcitriol is not being formed. So you can also put another X here. Well, that inhibition is not going on. All right. So calcium can't be reabsorbed in the kidneys, and so and it's not stimulated by vitamin D to be absorbed in the gut, so we get a decrease in calcium. And the only place that we can get calcium is from the bones. So we start releasing calcium from the bones because we're not reabsorbing it in the kidneys, and we're not absorbing it in the gut. And so we get this increase in PTH from lack of inhibition. We are shutting off the inhibition mechanisms, and we're getting an increase in PTH. So phosphorus in CKD, phosphorus, again, as our kidney function declines, our phosphorus elimination is decreased, which means that the serum phosphorus, so the phosphorus in the blood goes up. That serum phosphate or phosphorus binds to the serum calcium, and that decreases the calcium levels. So we get hypocalcemia, and we get an increase in PTH. So the role that phosphorus plays in this issue is that our phosphorus goes up, which leads to our calcium going down. Low calcium is a trigger for PTH release, and that increases our PTH. Any questions on phosphorus?
I have a question, Dr. Ho.
Mhm.
So, when the phosphorus binds to calcium, it also will decrease in the blood, right? Or
I'm sorry, can you repeat it one more time?
if the calcium, if the phosphor, like the phosphate binds to calcium, will it also decrease in the blood?
It will decrease a little bit, but there's so much extra that's not going to have enough compensation. It'll still be high, but it'll decrease it marginally.
Thank you.
Yep. But because we're also not reabsorbing, because we're not also reabsorbing the calcium because the kidneys aren't working, that's going to have a bigger effect on the calcium because we're not reabsorbing the calcium. We're not absorbing it. We're not reabsorbing in the kidneys. We're not absorbing it in the gut. So we're starting out with low calcium, and what low calcium is there is being binded by the extra phosphorus. So that's why the calcium is going to drop even more, and it's going to be more significant because there's 3 different ways that we're losing calcium in the blood. So that's why calcium becomes low. So how does vitamin D play into CKD? So in healthy kidneys, all of us who have healthy kidneys, we are taking our inactive vitamin D that we're getting from our diet, and it's going into our kidneys and being hydroxylated to calcitriol, or that 125 active form. And this helps promote intestinal absorption of calcium and suppresses PTH production. So if we are absorbing more calcium, our calcium is going up, and that's telling the PTH to shut off, right? It's a negative feedback loop. If we have a reduction in that calcitriol, a reduction in that active vitamin D, the parathyroid gland senses that, and that also leads to an increase in PTH. So that PTH is being stimulated by the low calcium and the low calcitriol. So again, in CKD, that kidney is unable to hydroxylate the vitamin D to its final active form of this 125 dihydroxy D calcitriol. On the exam, it's going to say calcitriol because that's just easier to write than 1/25 dihydroxy. So you need to know that calcitriol is the active form of vitamin D, and that the reason that calcitriol is low in patients with CKD is because the kidney cannot hydroxylate it. So not only can we not hydroxylate and get this active form of vitamin D, this calcitriol, we have reduced number of sensors that leads to further resistance. And so between the low calcium and the low vitamin D, this is all contributing to that secondary hyperparathyroidism, increasing the PTH. So looking at it in a similar manner as we did with the phosphorus, the kidney function declines. The vitamin D is not able to be activated through hydroxylation in the kidney. We have decreased calcium absorption from the gut. So that leads to a serum calcium decrease, hypocalcemia, which leads to an increase in PTH. So when we put these all together, or when we put these both together, when we have CKD, and down here on this arm, we have decreased phosphorus elimination, increased serum phosphorus binding to serum calcium, and we get decreased serum calcium. In this pathway, we have the kidney is unable to activate that vitamin D through the hydroxylation. So we have low activated vitamin D, so that calcitriol, which leads us to decreased calcium absorption in the gut, which still leads us to decreased serum calcium, which leads to hypocalcemia, which leads to increased PTH. So that calcium in CKD, we have the increase in phosphate is the first thing that happens to trigger this whole cascade. And that leads to hypocalcemia because we're retaining the phosphate. So we're not having, then we're not having as much vitamin D converted to the active form. And our organs and receptors are being bombarded with parathyroid hormone. So they're becoming less and less responsive to the PTH that's hitting them and trying to stimulate the increase of calcium absorption. And it's trying to pull the calcium out of the bone. All right. But at some point it becomes resistant, right? So normally hypocalcemia will stimulate the secretion of PTH from those glands, and then the PTH helps to decrease the phosphorus reabsorption and increase the calcium reabsorption in the proximal tubules. This will lead to increased phosphorus elimination and increased calcium reabsorption to retain the blood and offset the hypocalcemia. But when that GFR is less than 60, so in CKD, that mechanism fails. Right? And so that mechanism fails, we start getting the phosphorus to be retained and not getting into the tubule to stimulate. And that starts to lead to calcium loss from the bone. So that low calcium is then what leads to the increase in PTH. Normally, PTH will decrease the renal excretion of calcium. So we're going to hold on to the calcium. It's going to increase the renal excretion of phosphate. So we're going to get rid of more phosphate. And it also enhances the calcium mobilization from the bone. That's how it normally works. But when we get a GFR less than 60, that PTH starts to rise. And we get secondary hyperparathyroidism that leads to hyperplasia of the parathyroid gland. So the glands get bigger. Hyperplasia means they get bigger, bulkier because we're overworking them. And then we start getting the manifestations of the mineral bone disorders. We start getting skeletal manifestations. So things like osteoporosis and fractures. So I would write skeletal, osteoporosis, and fractures here. And non-skeletal, which would be the calcification of the vasculature. Right, so that's kind of a lot to take in. It's a negative feedback loop. Hormones drive me wild with their negative feedback. So spend some time looking at the flow charts to understand what is causing the cascade and what a low level or high level of phosphorus will do, what a low level of calcitriol will do, and what low levels of calcium will do. Spend some time understanding those effects, not necessarily being able to competently describe the whole process, but what the effects are, all right, and when they happen. Right, so our goals of therapy are going to be to normalize the biochemical parameters. And like the wording is controversial. Like we don't, it's going to be very hard to normalize. So we want to maybe improve the biochemical parameters. So again, we're not bringing them within normal limits. We're trying to bring them to a level that prevents complications and prevent or minimize consequences. So we're going to try and prevent and minimize um, like the osteoporosis, the bone fractures, the calcification of the vasculature. Right, this is a good place for a 5-minute break. I have 3:28, so that plus 5 is 3:33 to come back.
Recording stopped. Recording in progress.
All right. So when we have these issues with the mineral and bone disorders where the phosphorus is high, the active vitamin D is low, and the calcium is low, we're going to try to normalize, but more likely we're going to try to improve those levels so that we can decrease the consequences or prevent the consequences. So we always start with non-pharmacological. And so we're going to think about our dietary phosphorus restriction. We can do dialysis, which Dr. Gonzalez is going to talk about tomorrow. And we can do a parathyroidectomy, which is definitely not us. Right? Like us pharmacists are not going to do surgery because that would definitely cause harm. So thinking about the dietary phosphorus restriction, our high phosphorus foods are meats, dairy, dried beans, nuts, peanut butter, soda, beer, preservatives. And like almost all of these are things that I eat. So I hope I don't ever end up with kidney disease and main staple of my diets. Right. So we can recommend to limit them, but phosphorus is pretty much everywhere. And so limiting it is not really going to be super helpful. Right. In dialysis, we can remove it directly from the blood. And then in a parathyroidectomy, they can take out part of the parathyroid gland, which can help reduce the number of cells producing the parathyroid hormone. So we need to think about pharmacological treatment because dialysis is a pretty extreme step. Parathyroidectomy is a pretty extreme step, and dietary phosphorus, because it's restriction, because phosphorus is so ubiquitous, is going to make it very hard to get to. So in pharmacological therapy, we're going to target the hyperphosphatemia and target the abnormal PTH. And here is my kid getting his fill of phosphorus. Milkshakes are a favorite of his, especially cookies and cream. It'd be so sad if you couldn't have milkshakes, cheese, peanut butter. My kid thinks the perfect snack is a scoop of peanut butter on a spoon because I'm like, no more treats, no more candy. You can have a piece of cheese, you can have yogurt, you can have peanut butter. He's like, peanut butter on a spoon? I'm like, yeah, that's fine. Yeah, awesome. And then he finds the biggest spoon in the drawer, like seriously, the biggest spoon, and takes the biggest scoop. And right before bed, it's all over one side to the other. Okay, so how are we going to treat this elevated phosphorus with drugs and help to maintain that serum calcium? So we're going to have phosphate binding agents. Okay, these are very much like our potassium binding agents that we talked about, the patiramir and the locamoa that bind to the potassium. Instead of binding to potassium in the GI tract, these are binding to phosphate in the GI tract. So we're going to not be able to absorb the phosphate in our diet because it's binding to this drug. And so if it's binding and we're not able to absorb the phosphate, we're going to get a decrease in serum phosphate. That's pretty simple mechanism. Like as far as mechanisms of action, that's probably one of the simplest mechanisms of actions, right? It's so simple I can teach it. We don't need a science person to teach it. All right, so what drugs do we have that are phosphate binding agents? So we have calcium binding agents. And so we have calcium carbonate. This is not the first time that I've talked about calcium carbonate with y'all, right? Like we talked about it as it relates to antacids in self-care. And so it is available over the counter as Tums, Oscal, Caltrate, etc. We're going to give this 3 times a day with meals. So since it's binding what's in our diet, we have to take it every time we eat. Right? No matter which product we have, if it's binding to what we're eating, we have to take it every time we're eating. So even snacks. So sometimes it's 4 to 6 times a day if we're eating, depending on our snacks, but we have to take it every time we're eating to bind what we're eating. So you'll see here that I have it circled TID with meals, TID with meals, TID with meals. I think I want you to remember that you need to take this with meals to bind the phosphorus that you're eating. We also have calcium acetate, which is Foslo, right? And when we're dealing with drugs that have calcium in them, we really need to be careful because we can have these increase the risk of hypercalcemia. And so these are non-preferred agents. Even though this one says it's first line, it's non-preferred because of the calcium in it, because it can lead to hypercalcemia. Again, calcium agents are non-preferred because they have the increased risk of hypercalcemia. And they cause constipation. You should remember that calcium causes constipation. Calcium, C, constipation, C. We talked about this. It doesn't just bind our phosphate, it binds you up. It doesn't just bind with the acid in our stomach, it binds you up. So constipation is still an issue with this. One of the ones that you probably see quite commonly if you work in a hospital, maybe with patients who have dialysis, or in a community pharmacy, is sevelamer, carbonate or hydrochloride. So the Renvela or the Renagel, right? And so this is the one that we want to be thinking about, okay, as first line. Right? It is not calcium based. It is oral. Right? It is generally pretty well tolerated. It can have some nausea, vomiting, diarrhea, but doesn't every single drug have that ADR profile? So nothing really specific about it. You notice that there's no risk of hypercalcemia with it. So this is really a great option, y'all. It's first line in the guidelines, but it still has to be taken 3 times a day with meals. And it's still going to bind to other drugs, other chemicals. So we do need to be mindful of drug interactions with it. Right? We also have some drugs that are used in hemodialysis only. So ferric citrate, sulfuric oxyhydroxide, and lanthanum carbonate, and all hemodialysis only. I think the one that you see most commonly is this one, like in a community pharmacy, at least when I last stepped foot in a community pharmacy, but that was a long time ago. So just be aware about my experiences in community. But this is a really big chalky tablet, and they usually have, like, if they're getting a 90-day supply, they usually have like 3 or 4 bottles of this. Because again, it is you're getting this much in divided doses with meals. So that's a lot of really big chalky tablets in a 90-day supply. Right? We also can use aluminum hydroxide, but I would say that this is really never an option because of the aluminum toxicity. Right? And you get neurotoxicity with aluminum, and we talked about that when we talked about using it as an antacid, right? In patients with poor renal function, we get aluminum toxicity, which leads to neuro effects. So I would say that aluminum hydroxide, even though it is a phosphate binding, is never really an option. So there's a lot of information on these. I want you to know the generic names. I want you to know that they are multiple times a day with meals when people eat. And I want you to know that these ones are for hemodialysis only, that calcium can cause hypercalcemia, and that aluminum hydroxide is never the answer. Right? So if I were summarizing these 2 slides, that's how I would summarize them for studying purposes. Any questions on that?
We have to know the doses.
Absolutely not. That is not a good use of your brain power. just that you take it 3 times a day with meals, at least 3 times a day, maybe more. Right, so again, reiterating some key points, these are all equally efficacious as long as they're adequately titrated to the appropriate dose. They must be taken with meals and or snacks. If you miss a dose and your food is already absorbed, you're gonna skip the binder because it's gonna have nothing to do. If the food and the binder are not in the GI tract at the same time, it's not going to work. Drug interactions, so binding interactions with levothyroxine, quinolones, tetracyclines. This is not new. This is similar to what we talked about with the antacids, right? Do you remember that almost a year ago when we spent that time talking about antacids? Oh, it was actually like, oh yeah. All right. So whenever you see levothyroxine, quinolones, or tetracyclines, you need to think binding. Whenever you see binding drugs, you need to think that these are going to bind to levothyroxine, quinolones, and tetracyclines. Right. Choice of agents should be considered based on patient stage, other markers, and other drugs and ADRs. So again, Kadogi favors non-calcium binders. So really that sevelamer is really our top choice, especially for patients who are not on dialysis. All right. And we want to restrict the calcium-based agents if a patient has hyperglycemia or hypercalcemia for sure. And then for patients who are on dialysis, we want to use the dialysis to remove the phosphate, but sometimes we might need something in between dialysis sessions. So we might choose either the sevelamer or we might choose that lanthanol if we need a little extra help in between sessions. But usually for dialysis patients, we're going to try to use the dialysis to pull that out. There is a new drug that was approved in 2023, but it hasn't really taken off yet. It's I can't say the brand name. Exposa. Yeah, I can. Exposa. If I just stop to think for a second. Exposa. This is Tananapor. Tananapor. Where have I talked to you about this drug before? We've talked about this together before. I also couldn't say it then when we talked about it.
IBS, I think.
Yeah, Victoria, it is. We do talk about it for IBS. It has a different brand name for IBS. I can't think of the name of that right now, but it was first approved for IBS. They created a new brand name for CKD. And so this is an add-on therapy for patients with dialysis who have an inadequate response to the binders. It has a different mechanism of action, so it's not a binder; it's an exchanger. So it's an oral sodium hydrogen exchanger that's going to inhibit or inhibitor that decreases the phosphate transport. So we're not going to be able to absorb the phosphate across the intestinal lumen. So still essentially the same effect. We're not binding, but we're not transporting the phosphate. But both ways we're preventing absorption. It's twice daily before morning and evening meals. But again, it's going to be really hard for patients to get this because this is the FDA approved indication, and the FDA says that they have to have CKD, be on dialysis, and an add-on therapy to patients who have inadequate response or intolerant to any phosphate binder. So no insurance company is going to approve this until they have met all these criteria. So it's going to be really hard to find patients that actually meet criteria for this drug. And then we have like the cost benefit. This drug is a high cost, low value, because again, we're looking at phosphate levels, which are serum levels, which are surrogate outcomes, not clinically meaningful outcomes, right? But don't spend too much time studying this because again, it's not readily available to patients. So we talked about what to do when our phosphorus is high. We're now going to talk about what to do when our PTH is abnormal. So that secondary hyperparathyroidism. As a reminder, we have the decreased phosphorus, which leads to decreased serum calcium, which leads to hypocalcemia. We have the decreased ability to hydroxylate the vitamin D to make it active, which leads to decreased serum calcium, which leads to low calcium. All of that leads to increased PTH. If a person is not a dialysis person, we don't really know what the optimal levels of PTH are. So again, these are patients who are not on dialysis and they have secondary hyperparathyroidism, so their PTH is elevated. Their GFR is less than 60, but they're not on dialysis. We don't know what goal we're trying to hit. We know that the PTH is a larger player in managing that calcium, phosphate, and vitamin D. So we're really watching when using these drugs that target PTH in patients, watching their phosphate levels and calcium levels in the blood and adjusting the PTH drugs based on the phosphate and the calcium levels, okay? PTH level is going to tell us how much the gland is being activated and how much the drugs we are giving are helping, but there's not really a goal level PTH that we're aiming for. We're mainly looking at the phosphorus levels, the calcium levels. When we think about what agents we're going to use for patients that are non-dialysis and have high PTH, we're really going to want to try to use the calcitriol and vitamin D we're not going to want to use the calcitriol and vitamin D analogs routinely because those are not just for an elevated PTH. Those are going to help with our calcium absorption more than anything. And so these aren't to treat PTH, high PTH. We might consider adding them in later stages so that stage 4 and 5, as the hyperparathyroidism progresses, so they have really severe progressive hyperparathyroidism, that's when we might consider using them to suppress the PTH. Evidence shows that using these agents in patients who are non-dialysis doesn't really help outcomes that much and just increases the risk of hypercalcemia. And so we're like, our risk versus harm is, weighing our risk versus harm is not really there. These are going to tend to cause more harm unless they have really progressive hyperparathyroidism and they're stage 4 or 5. So we're going to try and avoid these in these patients. If the patient has dialysis, is on dialysis, so they're CKD stage 5 and they are on dialysis, so they have end-stage renal disease, their kidneys are no longer functioning, they're not able to remove toxins from their bodies because the kidneys don't work. These patients might require PTH lowering therapy, and we can use a combination of different drugs that we have based on the other parameters that we're tracking. So again, we're tracking not just the PTH levels, but the calcium levels, the phosphorus levels, and the vitamin D, the calcitriol levels. So based on the PTH, the phosphorus, the calcium, the calcitriol levels, that's how we're going to decide which drug we're going to use for these patients. The guidelines, these are the older guidelines, and the older guidelines kind of give us a clear path to how we're going to pick drugs. So if a patient has hypercalcemia, we're going to reduce or stop the calcitriol or the vitamin D analogs because these cause hypercalcemia. If they have hypocalcemia, we're going to reduce or stop the calcium mimetics because calcium mimetics cause hypocalcemia. If the PTH levels fall below 2 times the upper limits of normal, we're going to reduce or stop the PTH lowering therapy. Let's talk about these agents. First, we have the vitamin D and vitamin D analogs. Right, so we can get ergocalciferol and cholecalciferol over the counter. But ergocalciferol is generally our plant sterols from our diet, and cholecalciferol is from skin and using UV light to convert it. Anybody who does not live on the equator is going to be vitamin D deficient. There's like not enough sunlight that somebody can get if they don't live on the equator to convert their to active vitamin D. Also, there are risks with the sun, right? The UV rays increase your risk of skin cancer, and so and sunblock does prohibit that conversion to active vitamin D. So we should not, like, we should be advising going out in the sun for activity and for our mood, but people should be wearing sunscreen, cover up. We should not be advising people to get sunlight or to get active vitamin D. It's just not going to work. There's not enough sunlight outside the equator area for that to happen. Most people are getting it through their diet and the ergocalciferol and the plant sterols. These are both pharmacologically inactive. How well do you think that they are going to work in a patient who has progressive CKD? What stops working in the kidney when we have CKD, especially at that 30, 40, GFR of 30 or 40? What needs to happen for these to work in the body?
Hydroxylation.
Yeah, they need to be hydroxylated. So again, write this down. These need to be hydroxylated to become active. They need to be hydroxylated to become calcitriol. Where are they hydroxylated? In the kidneys. If the kidneys aren't working, there is no hydroxylation happening or very little hydroxylation happening. So we can give these all we want. But if the kidney is not working, they are not going to be hydroxylated. They are not going to be converted to calcitriol, and they are not going to work. Does that make sense? See a couple head shakes. So even though we can get them over the counter and they're low cost, they're not high value. They're not even medium value. They're not mid. You know, they are low value. They are low cost, low value because the kidneys are not working to hydroxylate. So that brings us to calcitriol. This is pharmacologically active. This is our active form of vitamin D. This is our hydroxylated ergocalciferol, cholecalciferol. This one is hydroxylated. It comes in oral and IV formulations. This is active vitamin D. It is going to increase our absorption of calcium. So it is going to cause hypercalcemia. So if a patient has normal calcium, we're not going to want to use calcitriol because that is going to cause them to have hypercalcemia. We would only use this in somebody who has hypocalcemia. So I would write down patient should have hypocalcemia to start. And the same is true for paracalcitol and calciferol. All of these can cause hypercalcemia, and they should not be used in patients who have normal calcium. They should be only used in patients who have hypocalcemia. Dr. Calciferol is a prodrug and it requires hepatic activation. So if a patient also, has CKD and luckily they have, unluckily they have hepatic failure, they're not going to be able to use Dr. Calciferol because they're not going to be able to activate that. We have the newest analog called calcifediol. This is a prohormone. of the active vitamin D3, specifically used for hyperparathyroidism. It has less effects on calcium, but it's still possible to cause hypercalcemia. This is a very high cost medication. I didn't look to see what the criteria was to get it for our insurance company, but I would imagine that you have to step through calcitriol and fail calcitriol to be able to get this drug.
So a lot of patients,
A lot of patients may have difficulty accessing this drug. Right, but any of these should not be used in patients who have normal calcium. They should be reserved for patients who have hypocalcemia. And if I hadn't said that enough, do not use these in patients who have hypercalcemia. Again, remember that these are going to help increase calcium absorption from the gut. That's going to increase the serum calcium, and that's going to inhibit the PTH secretion. So that's how these work. All right, they increase calcium absorption from the gut, increase the serum calcium. When the serum calcium goes up, that's a negative feedback to the parathyroid hormone to say, stop making parathyroid hormone. I hope you like negative feedbacks, because whoever teaches you thyroid is going to talk about negative feedbacks. Hopefully they do a better job than I do. All right, so this is their mechanism of action. Are we good to move on to the next ones? Any questions on the vitamin D analogs? So next we have our calcium mimetics. And so we have an oral one, which is cinacalcet or Sensipar. This is the one I see more frequently because it's orally. And we also have calcitide, which is IV. So that's probably why I don't see it, because it's given during or right after hemodialysis. So I've never worked in a dialysis center, so that's why I've never seen this. But the cinacalcet I have seen on patients' med profiles and in the community pharmacy. So that's oral. You take it with food, not because from a tolerability standpoint, not from an efficacy standpoint. It's daily dosing. There are a lot of drug interactions with it. So they both work the same way. They're going to increase the sensitivity of the calcium receptor in the parathyroid gland. So they're going to act like calcium. They're going to be like, hey, we're calcium. And they're going to go to that parathyroid hormone and shut it off to decrease the parathyroid hormone production. They're going to trick those calcium receptors to thinking there's a lot of calcium around. All right. These are really great to use in patients who have hypercalcemia and phosphate levels, in addition to the high PTH levels, because they're basically telling the parathyroid, hey, the calcium is too high, stop reabsorbing it, stop deconstructing the bones to put it in the blood, just stop hanging on to the calcium and getting more calcium. So these are particularly helpful in patients who have high calcium. They are not safe in patients who have normal or low calcium because they cause hypocalcemia. So we are not going to use these in patients who have normal or low calcium because it's going to make it worse. Because it's working on electrolytes, it can have issues with lowering the seizure thresholds. If we do too much correction of the electrolytes and get something too low or too high, that can cause a seizure. Side effects besides lowering the calcium include nausea and diarrhea. Taking with food, I'm sorry, is an absorption issue. So it helps with absorption to make it work better. It's not a binding issue, but it does help with absorption to make it work better. Any questions on these? So vitamin D analogs like calcitriol, we're going to increase calcium levels. Because again, that vitamin D works to increase calcium through GI absorption, right? The calcium mimetics like cinacalcet decrease the calcium. Because it thinks that it makes the body think that it has enough calcium and doesn't work to get more.
Is going to make it
Is
think
going to
it
make it think it has more calcium. It's going to
shut down the PTH,
which is going to shut down reabsorption, which is going to shut down calcium reabsorption, which is going to shut down mobilization from the bones. Immobilization from bones. This is really terrible. I need to get my pen working again. Right. So if a patient has low calcium levels, which drug are you going to use?
Vitamin D analog.
Vitamin D analog.
Right. Because the
Right, because the vitamin D analog is going to increase our calcium levels.
The answer.
The
thought I
answer is
had
right
this
on
set
the, I
up
thought I
to-
had this set up to,
Oh my gosh.
oh my gosh. If the
Calcium
calcium is high, we're going to use a
Mimetic,
calcium
because that's going to
mimetic
help
because
bring the
that's going to
calcium
help bring
down.
the calcium down. All right, so if none of this works and they're still having issues, we're going to go for a parathyroidectomy. We're going to want to do bone mineral density testing to make sure that the patients do not have osteoporosis. We might need to do a bone biopsy and we might have to treat osteoporosis. And then we need to assess for vascular sequelae, so calcium studies of the vasculature if the medicine does not work.
So this is an
overview of everything that we have talked about as it relates to the kidneys. This number one describes what happens with the phosphate. Number two describes what happens with the vitamin D and the calcium and the PTH. And number three describes what happens with the EPO. So this is a good review of everything that we've talked about and how it happens in the body for you. Um, so I think, are there any questions about anything we talked about today? Or what questions you have about what we talked about today or up until this point?
I have a question that is not 100% real, but I think as a pharmacy student, I should know. Why would they keep um reformulating the brands? Is it to extend the patent, or would that not allow them to do that?
Um, so I think it would allow the patent. I'd have to go and look at the dosing if the dosing is
Yes,
different for the
indication.
IBS indication. I didn't look deeply into that last night. So the dosing might be different, so they might be creating a different tablet strength for that. But yeah, generally it's to extend the formulary.
Yes.
We're seeing a lot with semaglutide right now. We have diabetes formulations, injectable and orally, and now they're creating a new oral semaglutide for weight loss and the other indications that is different than the formulation that is for diabetes.
So
really fascinating time.
yeah, so the IBS dose
Yeah,
is
so the
50
IBS
milligrams.
dose is 50 milligrams twice a day. And so
Hyperphosphatemia
the
dose is 30
hyperphosphatemia
milligrams
dose
twice
is
a
30
day.
milligrams twice a day.
Once you play with the dosing that allows them to.
Yeah,
Yeah, because they didn't,
the dose of
they
30
used a
milligrams
dose of
twice a
30
day.
milligrams twice a day in these patients instead of 50 milligrams, which is what they've already produced. So they essentially created another
Dose for a different
dose for a different indication. So they're going to use a different brand name to help extend that patent.
Thank you.
Yeah, my pleasure. All right. If anybody wants to stay on and tell me what they've liked and what they haven't liked about their cases, please let me know, and then I'll have a plan for Friday. I believe your evaluations are open if Canvas ever starts to work again. So please make sure you take
Me
some
and Dr.
time to provide
Gonzalez.
me, Dr. Gonzalez, and Dr. Yoshi some feedback on the class. Remember that they're mandatory for your was it PHRD 800. So please make sure you get them done. And I am always really interested in feedback. Try to make adjustments based on what you say, if there seems to be a consensus on that. Tomorrow is in person with Dr. Gonzalez, so please make sure that you are there for his lecture on dialysis. And then again on Wednesday, we'll be back on Zoom. All right. Email me if you have any questions. Please do
Studying
not wait
until
to
the
start
weekend.
studying
Please
until the
start
weekend.
trying to
Please
fit some of
start
that in.
trying to fit some of that review in now. Because I think this section might be easier than the last section, but there's a lot more drugs to remember. And that can be tricky because they're not drugs that we
top
see all the
200
time. They're not
drugs.
top 200 drugs that we're constantly dealing with. And I think that's the hardest part about this section is learning the drugs because they just are not
Common
those
drugs. So,
common drugs. So please start working on that now so that you are well prepared for the exam next Tuesday. Okay.
I will stay
All right,
on.
so I will stay on and then again reach out if you need anything.
Recording stopped.
Um, the whole one feedback that we have had, I don't know if it's that it's hard to do or like it's not an option, but we have been missing points because of the forward, like not like it allows you to go forward even if you don't answer the question. So like if you double click for like by mistake, you're gonna skip that question. So I don't know if that's something that could be fixed, but yeah.
I believe it is. I believe it is. I think I can put in like missing answer required or something like that as a parameter. So it'll require you to put an answer in.
Before you go forward.
Excuse me, before you go forward. Or answer required, I think.
That's good to know.
That's good to know.
Okay.
Yeah.
Thank you.
Yeah. Any other thoughts, Jose?
The the other, I don't know, maybe because of the logics of how the cases go, but the other thing would that I would have been good for you not to lose too much time on the open, like on the sections where you can write yourself. um if it doesn't alter like the logical order of the exam, I would put the multiple choice questions before, just because those are easier points, and then you can spend more time on writing when you have to write out the answer. Yeah, that was the other feedback I would give.
Okay, thank you. That's very helpful.
Mhm.
What other feedback do you have?
Those are the things that I had.
Dr. Hope. Dr. Hope.
Hi, Ernesto.
Dr. Hope. So also, I think timing also, like people don't get too much time to finish, and some people just, and including myself also, like have to rush it because now we can't go back, and as Jose said that there's some cases that you need to like write stuff, and maybe you get like stuck on that, and or maybe and you don't know there's like other cases that you need to write on and that are present in the forward selection or or in the quiz. So that's another thing that um, I think, yeah, um, I have feedback on, like maybe yeah, I agree with Jose. Maybe putting like the ones that are for writing first, or multiple choice first, and then like the cases later, because then you don't like have a surprise case that you need to like write on. And
Yeah, you were not expecting it.
yeah,
You were not expecting it.
yeah,
Scan and
Oh, yeah, because you can't
prioritize.
scan and prioritize.
Yeah, exactly.
yeah.
Have you been able to use notes or,
Able to use on your
what have you been able to use on
so
your
far.
cases so far?
Yeah, we can use our PowerPoints, our notes, so that's very helpful also. But myself sometimes I get like caught up writing a lot of technical stuff, and then you're like, oh my god, like I have to write another thing or three cases more, and you don't know what you need to write, or it's multiple choice. So
Yeah, it's a little hard, as you said, like because you don't have a gauge of, I don't know if that's the word, but a gauge or like an idea of like how much time would you have to spend on the question, because it might be a couple like case questions, and but you have no clue until you go forward. So is it worth it for you to actually like spend time on that question, or are you actually like shooting yourself in your foot by spending too much time there, and then you end up like just pushing forward just because like you're yeah, you're just going blind. So I think that the forward, yeah, like not going back, if you can do the multiple choice questions first, it would. And then also we could have like, you don't have to change it too much, but like you could tell us like, oh, so the last four questions are like, um I forget how you call it in English, but like, yeah, the you
Essay?
write
For
them.
the
Yeah.
answer?
Yeah, exactly. The last four questions are for answers, so it gives us an idea of how to strategize and utilize our time.
Okay.
Right. Thank you for hosting about
Yeah.
this now.
Would you
Yeah.
have you always done
Would
just
you,
one?
have you always done just one case, like one patient case, or has there been multiple cases, or do you have a preference